550 cases, at least 90 deaths. And WHO is now publicly asking Uganda to do the opposite of what Uganda is doing at its border.
This is Ebola Watch, and Kara. That border disagreement is the story I've been circling all week. Two governments, two postures, finally out in the open.
We need to walk carefully through the case jump from CIDRAP, MSF's new access principles, and Tedros's direct appeal to Kampala.
And a UN headline using the word untreatable. Let's start there, because that's not a word you headline lightly.
550 plus as of June 8th, up from 452 on the 4th. That's roughly 100 cases in 4 days, Daniel.
So that acceleration question I kept asking, we've got an answer. The curve's moving.
Partly answered. All week I asked whether the jumps were lab reclassification or real transmission. 100 cases in 4 days leans hard toward ongoing transmission. But the Bundibugyo strain still makes that read messier than I'd like.
Okay, but the death math. At least 90 deaths on 550 confirmed, that's north of 16%, and that's before we touch the suspected death overhang I've been tracking.
And at least 90 is the part that worries me. That's where the suspected versus confirmed accounting hides. CIDRAP is being honest with the hedge. We should be too.
Which is why I won't quote a single clean fatality rate today. The denominator isn't clean.
On MSF, they put out equitable access principles for Bundibugyo-specific tools June 8th. There still isn't a licensed vaccine or approved treatment for this strain.
So let me get this straight. They're writing the rule book for who gets the drug before the drug exists.
That's the sharp edge of it. They're trying to set the terms of access before the tool exists, so the framework doesn't get improvised under pressure later.
My question is, what that document actually obligates anyone to do. Principles on paper for a vaccine nobody's made yet. Does it bind a future manufacturer, or is it a flag in the ground?
Now the border. Tedros directly urged Uganda to reopen its crossing with Congo. WHO is arguing that closure undermines the transparency that controls the outbreak.
Name it plainly. An official health authority is telling a government its border policy is making this worse. You can hear the daylight between two powers, and each one controls real crossings.
And it turns the Kinshasa-Kampala relationship into a disease control variable, instead of just diplomatic background. WHO is making an epidemiological case in diplomatic clothing.
For worried travelers, a closed border doesn't mean contained. WHO's whole point is that closure can hide the transmission you'd want to see.
One more piece. Muyembe told the new Humanitarian the response has to be anchored locally.
And that lands right on health worker protection. I asked 2 episodes back if infection prevention was reaching staff. Local ownership here is staffing math as much as governance.
With workers among the infected and the dead, Muyembe's point is structural. You can't run this from outside if the people running it are the ones at risk. From U News.
The top UN aid official in the Democratic Republic of the Congo, DRC, is in Ituri province, the epicenter of the country's Ebola outbreak, for a 3-day assessment visit, as the confirmed case count reaches 515 across 3 eastern provinces.
U News has the DRC tally at 515 confirmed across Ituri, North Kivu, and South Kivu, with 91 deaths. And the callback I owe listeners, confirmed cases have now climbed past 500 in those same 3 provinces. And the detail I keep coming back to, roughly 95% of cases are in Ituri. Damien Mama, the interim humanitarian coordinator, landed in Bunia Sunday. So the response is going where the curve actually is.
Kara, the headline says, untreatable. Flat out. No approved treatment, no licensed vaccine, 3 candidate vaccines still in development. That word's been hovering all week, and now the UN's putting it in the title.
Right, Bundibugyo. It's harder to control than the Zaire strain we built vaccines around, and that's exactly why the field visits to Nyankunde matter. 12 recoveries against 91 deaths tells you how thin the toolkit is.
12 people recovered, out of 515. I want listeners to sit with that ratio for a second.
CIDRAP writes,
The Ebola outbreak in the Democratic Republic of the Congo, DRC, and Uganda has reached more than 550 cases, according to the latest updates from the Africa Centers for Disease Control and Prevention, Africa CDC. The DRC has 544 cases and 88 deaths, all confirmed Ebola Bundibugyo, and Uganda has 19 cases and 2 deaths.
The CIDRAP figure as of June 8th is more than 550 cases, 544 in the DRC, all confirmed Bundibugyo, 88 deaths there, plus 19 cases and 2 deaths in Uganda. 4 days ago, I was looking at 452.
Nearly 100 cases in 4 days, Kara. All week, I've been asking if the curve's accelerating. This pretty much answers it.
It does, and here's what's changed in how I read it. Earlier this week, I kept asking whether the jumps were lab reclassification of suspected cases catching up. At this pace, with this consistency, that's harder to explain as paperwork. This reads like ongoing transmission.
And Ituri's carrying almost all of it. 515 cases in one province, Bunia at the center. So for anyone trying to picture this, think concentrated. Ituri, Bunia, the same epicenter we've been naming since day one.
WHO puts the case fatality rate at 17.4%, and they say plainly that's likely an underestimate, because deaths before the outbreak declaration are still under investigation. That hedge is exactly where the suspected death accounting lives.
And 34 health workers infected, 5 dead. I asked 2 episodes back whether protection was actually reaching the people on the ground. Kara, that number is the answer, and it's worse than I wanted it to be. One small thing I'm holding on to in all this, 12 patients have recovered. For a strain UN News is calling untreatable, that number matters.
It does, and the word untreatable is precise here. There's no licensed treatment for Bundibugyo. Those 12 recoveries are supportive care standing in for the drug we don't have. This one's from Eastern Herald.
Tedros Adhanom Ghebreyesus, the WHO's Director General, said the border closure Uganda ordered in late May does little to stop the virus and a great deal to weaken the response to it. Blanket travel restrictions are ineffective, he said, and they discourage the transparency that saves lives. I hope they reconsider, he said of Uganda's authorities.
Okay, here it is in the open. Tedros stood inside an isolation ward in Kampala and asked Uganda to reopen a border Uganda deliberately shut. 2 authorities, opposite directions, on the record.
And his argument is precise, Daniel. The closure is epidemiologically counterproductive. Blanket restrictions push countries to hide cases to avoid the trade hit. And concealment is what kills you in an outbreak.
Mpondwe's been shut nearly 2 weeks. Families, traders, medical referrals. That's the crossing. So when WHO says reopen, Uganda's heard them and said no.
I hope they reconsider is about as far as a Director General can lean diplomatically. But notice the framing. He's centering transparency over border traffic. It's the disease control case, dressed up politely. MSF Access writes,
Médecins Sans Frontières, MSF, is deeply concerned by the impact of the outbreak of Ebola disease caused by the Bundibugyo virus, officially declared by the Democratic Republic of the Congo on 15 May 2026. This outbreak once again exposes persistent failures to prioritize, fund, and produce accessible medical tools for diseases disproportionately affecting low- and middle-income countries.
MSF published its access principles for the Bundibugyo strain yesterday, June 8th, And what makes this sharp is the timing. They're writing the rules for tools that don't exist yet. No licensed vaccine, no approved treatment for this virus.
Right, so this is a principles document for a drug that hasn't been invented. Which sounds backwards until you hear why they're doing it.
It actually makes sense. MSF points straight at COVID and past Ebola outbreaks. If you don't lock in who gets access at the start of R&D, low-income countries end up last in line when the tools finally arrive. They want enforceable arrangements embedded from the outset.
So the question I've got, what does this document actually obligate anyone to do? It's MSF calling on donors and governments. Is there a single signature on it that binds a manufacturer?
No, it's a framework. Nobody's signing a contract here. But framing the terms before the tools exist is the only window where equity is even negotiable. Once a treatment is in a vial, the leverage is gone. That's the bet they're making. Here's Laban Casimira at the new Humanitarian.
The response to the Ebola outbreak in the Eastern Democratic Republic of the Congo must be rooted in the country's local health structures and avoid asymmetrical suffering by treating those in state-controlled and rebel-run areas the same, says a leading Congolese virologist.
2 episodes back, I asked whether infection prevention support was actually reaching workers on the ground. Muyembe just answered it. Structurally. He's saying the whole response has to run through Congo's own health system, not get dropped in from outside.
And listen to the word he chose. Asymmetrical. He's warning against treating patients in state-controlled areas differently from those in M23-held territory. That's an epidemiologist's point before it's a political one. A transmission chain doesn't stop at a front line.
Right, which is the part that scares me. We've got 550 cases now, the M23 conflict running through the exact zone, and no vaccine for this Bundibugyo strain. Local anchoring is the only staffing math that works.
That's the link back to the MSF principles we touched earlier. Both are arguing about who controls access. Muyembe's framing the people. MSF is framing the tools. Same equity question from 2 ends.
If Ebola Watch helps you stay informed, please subscribe and leave a quick review wherever you're listening. It only takes a moment, and it helps other people find the show when they need clear updates too. You'll find links to every story we covered today in the show notes, so if something caught your attention, you can follow it there and read more. That's Ebola Watch for this Tuesday, June 9th. This is a Lantern podcast.